So good morning. The topic of today is visual system and its accessory visual structures. Here you can see one of very rare developmental defect, which is called cyclopia, and it was drawn by Odile Redon, a French symbolic painter. Please do not mix his surname with the surname of Henri Redon, who developed this Redon drainage for wounds and to remove blood or fluid from injuries, wounds, and sutures. Yeah, so that's just the beginning, and we should start to talk about the eye. The eye is composed of orbit, and the orbit contains eyeball and accessory structures of the eyeball. I think there is nothing new about the orbit, but we should a bit repeat it, that it's a fossa of the skull, which has got a shape of tetrahedral pyramid, tilted dorsally. That means the apex of orbit, which is formed by optic canal, faces dorsally or posteriorly, and the base of the pyramid, of the tilted pyramid, faces ventrally or anteriorly, and we call it adductus of the orbit. There are 4 osseous walls. The walls contain 10 openings, and the openings contain vessels, nerves, and some other potential structures. Maybe a new structure for you is something which is called orbital septum. Orbital septum is a frontal connective tissue plate which is located within the addutus of the orbit. And of course, there's an opening between the upper and lower lid, and the lacrimal gland is within the septum. Yeah, so this septum prevents the eyeball to fall out ventrally. Dorsally, there is superior and inferior orbital fissure, and the inferior fissure is closed by orbital membrane with smooth muscle fibers called orbitalis muscle. So that's a general introduction into the orbit, and your homework is to go through the osseous wall of the orbit again. They are listed in following slides, but I will skip it as we have studied this during skull topic. Yeah. What is also important is the relationship of orbit to the surrounding structures. So medially from the orbit, behind the orbital plate of ethmoidal bone, we can find the ethmoidal cells. The wall is very thin. It used to be called lamina papyracea, yeah, similar to papyrus, very thin one. And if there's an inflammation in ethmoidal cells, the inflammation can penetrate this thin bony wall and can enter the orbit, and the ethmoiditis can then change in orbitoethmoiditis. So the inflammation can spread into the orbit, into the structure surrounding the eyeball. Yeah? So that's clinically very important, that this medial wall is very thin. The caudal wall separates the orbit from maxillary sinus, and there's a special injury which is called blowout fracture. Blowout fracture of the orbit. And in case of this fracture, what happens? The inferior wall can be ruptured like this, and it can entrap a muscle which is lying on the inferior wall, which is rectus inferior muscle. And if it's entrapped, then all the movements of the eyeball are not possible. Yeah, so you have to repair it surgically. So this is the inferior wall, and below is maxillary sinus. Cranial wall is formed by orbital part of frontal bone, and above it we find the frontal lobe of the brain of telencephalon, so anterior cerebral fossa. But sometimes between that, if this is the frontal bone and here is the orbit, we can have usually in the anterior part, there can be the frontal sinus. So the frontal sinus can stretch dorsally between the roof of the orbit and the floor of the anterior cranial fossa, yeah? Anterior cranial fossa. So there can be the frontal sinus in between. As you know, the frontal sinus is very variable related to its dimensions and volume. And dorsally, it communicates via the superior orbital fissure with cavernous sinus, and via the inferior orbital fissure with pterygopalatine fossa. So these are the relationships, important one. And now we can go directly into the eyeball. So we are going to talk about the eyeball now. The eyeball is like a ball, like an onion, so it has got the layers. So which layers we have? I hope you know these from secondary schools, that we have the external or fibrous layer. Yeah. Then we have the vasculose or middle layer. And then we have the internal or nervous layer, which is retina. Yeah. So rods, cones, and other neurons. So these are three surface layers of the eyeball. And what is inside? Inside is vitreous body, which is this. It's a jelly-like structure. Then we have a lens, which you can see here. And then the spaces between cornea, which is part of the fibrous layer ventrally, is filled with aqueous humor and intra-eyeball fluid, which is located here. And its function is to feed the cornea and lens. In clinics, we divide the eye into anterior and posterior segment. As you can see, the posterior segment is not complicated. In the posterior segment, we have the vitreous body and retina. And in the anterior segment, we have the other structures like cornea, iris, the ciliary body, and lens. Yeah? So it's smaller but more complicated part. So it's an eyeball. The eyeball is a ball, so we can describe here some general structures like anterior pole and posterior pole. As you can see, the optic nerve, which is here, is all the time located medially, or we can say nasally, yeah, to the axis. Here is through the pole we have the axis, and this is laterally or temporally, yeah, lateral or temporal direction, and this is medial or nasal direction. So that's the axis, and then we have the optic axis, and the optic axis is a bit different. The optic axis goes through the yellow spot or macula lutea here. So two optic axes then converge. Yeah, if we have two eyeballs like this, and we have an object here, for example, a rampart of a castle. So then the axis converges towards the objects, and that's why we can see the object from two views. That means we have 3D vision. Yeah. So the axes converge. The axis of optic nerve, they diverge ventrally. Okay, then we have some other terms. Equator, and the equator is this one. And you may know that muscles insert, these muscles which insert in front of equator are called recti muscle, muscle which insert behind are called oblique muscles. We don't have any oblique muscle here shown. So this is the equator, and meridians are of course perpendicular to equator, so we have meridians like this. So this looks as an Earth globe, and this would be the North Pole and South Pole of a globe, if you look at it. So the equator is well visible in transverse section, in horizontal plane. So if you look into the patient, you see the equator. If you look into the eyes, you see the equator like this. This is the iris and pupilla, and the equator is like that. Oh, sorry, the equator should be this color. So the equator is like that. And the meridians are like that. And this is if you look into the patient's eyes. And here on the transverse section, of course, the equator is in frontal plane. If you have any questions, of course, you can ask. And if not, we move to the layers. We start with the fibrous layer, the external, which consists of sclera and cornea. Sclera forms majority. Sclera forms 5/6 of the external layer, and it means the dorsal 5/6 of it. It's composed of dense connective tissue, so it's not transparent. And the function is to maintain it, to support it. It's just an envelope, a cover. You should know the thickness concerning the surgical approaches, and the thickness is 1 millimeter dorsally, 0.5 millimeter in the middle at the level of equator. So it's very thin. As it's connective tissue, the tendons of extraocular muscles insert, of course, there. So that's the function. It's a insertion of the muscles, and it's a protective cover or envelope of the deeper structures. So nothing special about its composition. But there are 6 structures which you should know. We go through them here. And there are 3 layers. The layers are very easy. We have some proper substance, which is the dense connective tissue. And we have something externally and internally. Externally, we have a structure called episcleral lamina. It's not a dense connective tissue, but it's a loose connective tissue. So if you think this is the eyeball, and you would like to move it, so around you have another layer, and this layer is called bulbar sheath or vagina. And in between, we have this episcleral lamina. So here is loose connective tissue, and this general structure or this general scheme shows you also a joint. This can be a head of the joint, like in acetabulum, the head of femur, and this can be the fossa of the joint, in case of hip joint, acetabulum. And this is the fluid, synovial fluid. And the same for the eye. You have the eyeball. The eyeball is this. Then the sheath or vagina. So vagina bulbi is here. And the layer in between is episcleral lamina. Yeah. Of course, with some interstitial fluid. And it enables you to move the eyeball as a joint. Yeah, it's similar. In case of autoimmune diseases, there can be inflammation. The inflammation is then called episcleritis. Yeah, and episcleritis is usually autoimmune inflammation. So definitely this thin layer is clinically very important. On the other side, that means on the internal side, we have a structure or a layer which is called Lamina Fusca. Fuscus means brown. And why it's brown? As it contains melanocytes with melanin. Yeah, so it helps to form a black chamber inside the eye for good vision. So 3 layers of sclera, and now 6 other different structures which we have there. So first structure is this. Venous scleral sinus. It's a circular canal around the cornea within sclera. So if you look into the eyes, you can see the pupil and iris, and the canal is circular, so it's like here around that. That's important. You should know that it's a circular canal, and you can see it here. That's this structure from the section. Yeah, so it will be also on the other side. What is the function? I will talk about this a bit later. Yeah, then we have another structure. Another structure is called calcar. It's this one, and it's also circular structure. So you can see it here. Yeah. So it is also going like this around. So another circular structure, calcar, and it's just a process of sclera which is projecting inside this space. This space is called anterior chamber, camera anterior chamber, and it's filled with the fluid with the humor aquosus. And the last structure is this. If you look at it, it looks like a sponge. Yeah, it's spaces and structures. So it forms like a cave with many stalagmites inside. So it's called reticulum trabeculare because it's filled with trabecles. Yeah, so it's a network of trabecles. So it's something which looks like this. Or it should remind you of a comb. So it's a comb-like structure. Yeah, if you like to comb the hair, so you have the comb-like structure. It's called ligamentum pectinatum, pectinate ligament. And the spaces in between are called Fontana's spaces. So you have 3 synonyms for the whole structure which is visible here. Yeah. So again, it's called trabecular reticulum or pectinate ligament or Fontana spaces. And why it's like that? The fluid which is here, and it's called humor aquosus, it's absorbed here through the reticulum into the canal and then into veins. It is produced here in a ciliary body, we will talk about that, flows this way through the pupil, here and here. Yeah? So we need to understand that this is a space for absorbing. And if this space is somehow damaged, then the absorption of the fluid stops, and we will talk about the problems which then happens. So do you understand what is trabecular reticulum? That it's a meshwork or network of scleral connective tissue, trabecles. In between are spaces, and these spaces serve for absorbing of the humor aquosus of the intraocular fluid. Okay, perfect. If you understand this, then we can move to other structures. We have something which is called scleral sulcusal groove, and you can see it here. It's between sclera and the cornea, yeah? And it's very shallow groove. Yeah? This area we call corneal scleral junction in English, and in Latin limbus corneae. Yeah? So there are two different names. Limbus corneae, limbus like a collar, and in English corneal scleral junction. And on the surface we have this shallow groove, and if you have any small foreign body or a group of bacteria here, if you blink or wink, then the tears take all these structures away, but they can be stopped here. As it's a groove, it is not cleaned well, so it's called like a dead space, and it can be a potential site of spread of infection to the cornea. Yeah? So during the ophthalmology examination, you have to look here, and in case there are some foreign bodies or bacteria or so, you have to clean it. So that's the groove. And then we move dorsally. Yeah? So we leave the anterior segment and we go to posterior segment. And dorsally, you can see here is an optic nerve, and the optic nerve, the fibers of the optic nerve, of course, they leave the eyeball this way, and they have to go through the sclera. So they make a cribrose plate there, lamina cribrosa. Yeah? There is about 1 million of these fibers, so they have to pierce the sclera. So there's a lamina cribrosa, but it is not visible. The lamina cribrosa is this area, yeah? A dotted area filled with all the fibers. So there should be like 1 million of small openings. And the margins of it, I may do it with a different color. The margins are thickened, so you can see them as a circle or annulus. This thickened circle is visible if you look into the eye. We can look there in an examination method which is called ophthalmoscopy or fundoscopy, as you look into the fundus, into the base of the eye. Yeah. And on the fundus you see two spots. One of them is the blind spot, the other is the yellow spot. And just around this blind spot where the optic nerve leaves, you can see this thickened margins, which altogether the margins form a circle. That's why we call it scleral annulus. Yeah? And it's well visible on the ophthalmoscopy figures, as I show you later. Okay, 6 structures in sclera. Questions? Everything clear? Okay. The test in senses will be joint test of anatomy, histology, and embryology. So I'm going to talk about the histology a bit. You will have a special histological lecture with Dr. Uhlík on this topic, don't worry. And I will mention the histology a bit so you are a bit oriented. Yeah? So this is sclera. As you can see, the layer is composed of collagen fibers and nuclei of fibroblasts mainly. This layer is choroid or vasculous layer, so that's another one. Yeah, and then this is already beginning of retina. The retina is detached in histological processing, so this is so-called pigment epithelium. Yeah, you can nicely see the dark line. I'll come to this again. So very condensed connective tissue, that's sclera. So histologically a bit boring. Now let's talk about the other part of the fibrous layer, cornea. Cornea is the 1/6 of the external fibrous layer. It's located ventrally. So now we are going to talk about this layer. And it is a very unique, as it's perfectly transparent. It's transparent because it also consists of collagen fibers and fibroblasts, but they are perfectly arranged. They are so perfectly arranged that only 1% of the light is absorbed there. So the light passes through. Yeah. What are the dimensions? The dimensions are 11 to 12 millimeters. As you can see, vertically 11 and horizontally 12 millimeters. It means it is not perfectly round. Yeah, it's a bit flexed, but this is from birth. Yeah, so we call it astigmatism, which means non-perfectly curved part of the globe, and it's physiological one because your brain is used to that. Yeah. If it's more, if the difference between the vertical and horizontal dimension is more, then it's called pathological astigmatism, and you need to correct it with the glasses, so-called cylindrical glasses. Yeah. As cornea is a convex structure, yeah, it's a layer of a ball, but it's convex structure. It refracts light. And its optical power or refractive power is quite big. It's 43 diopters. Yeah? The lens will have only like 15 diopters. So that's very important medium to refract the light. Another important thing, it's avascular. Yeah? If there are vessels, it is not perfectly transparent. So it is avascular and it's fed by diffusion. Yeah? Sorry, fed by diffusion, and it's fed by diffusion from two fluids, from inside, yeah, intraocular fluid, humor aquosus. Humor means a fluid in Latin, aquosus, water-like, yeah, and externally from tears a bit, and from the sides, of course, capillaries, which are in sclera and in conjunctiva. Or conjunctiva. What is conjunctiva? Conjunctiva is this epithelial layer lying on sclera and then lying on eyelid. We will talk about this later, don't worry. Yeah? Okay, so it's avascular. If there are vessels in cornea, they are there pathologically and they appear after an injury or inflammation. Yeah? And of course, they worsen vision. And we have two structures. One is called corneal scleral junction or limbus. Yeah, we have already talked about that. That's this area of connection. And we have a vertex. Vertex is this point. It's the ventralmost point of the eyeball. So it's the same as the anterior pole of the eyeball. And it's the thinnest part of cornea, and you should know how thick it is. As we have now methods which help us to treat myopia with laser, that with laser you erase part of cornea layer, but if the cornea is thinner than 400 micrometers, then you are not able to perform this, otherwise it will be too thin. So normally it's 555 micrometers. It can be a bit more, a bit less, of course, but if it's too low, then you are not able to perform this refractive surgery, yeah, in myopia. So remember the vertex and the thickness, which is 1/2 millimeter. At the limbus, it is like 1 millimeter approximately. Yeah. Okay. Now we go inside. We have 5 layers, and they are important, these 5 layers, concerning the injury. Okay, we are going to start in the middle. So we have some proper substance. And on the proper substance, we have 2 epithelia. Anterior epithelium, which is derived from superficial ectoderm. So it's like a skin. So it's a stratified squamous, but non-keratinizing. Yeah? If there would be keratinization, you have again problems with the dead cells, which can block the light to go in. So it's non-keratinizing. Yeah? And we have posterior epithelium, which is simply squamous. So sometimes it is called endothelium, as you know, endothelium is also simple squamous epithelium, but endothelium is only in vessels. So we do not call it like that, because endothelial cells has got special receptors and metabolism, and these cells of the posterior epithelium of cornea have a different marks, different receptors, different antigens. That's why endothelium is not a good term. And in between are 2 layers. And as these layers are not only basal laminae, but they are a bit thickened, we call them limitating laminae, anterior and posterior. And please, in ophthalmology, they use these 2 terms, as they are shorter, to say the cement membrane than posterior limiting lamina. So learn it. Yeah, 5 layers substance, 2 limiting layers, and anterior and posterior epithelium. Okay, so if you look here, then it's easy to see the whole proper substance, substantia propria. This is the outer stratified non-keratinizing squamous epithelium. This is the posterior simple squamous epithelium. And then we have posterior and anterior limiting lamina. Yeah, so that's the layer. This is then anterior chamber with humor aquosus, and this is outside with tears. Yeah, would be on it. So now a bit of histology. You will talk about this in histology, so I don't go through this in detail. I'll just give you a general overview. So as for the stratified squamous non-keratinizing epithelium, it has got usually 5 layers, and you should know how thick it is. It regenerates very quickly. Yeah, it's quite similar to intestine, for example. Yeah, it's 5 days. It is in intestine, 6 days here. At margins, you have some dendritic Langerhans cells of the immune system. What is important, even inside the epithelium, we find free nerve endings. So cornea is very sensitive. It's painful to touch it, and of course it serves, or the branches of ophthalmic nerve, they serve as the afferent limb of the pupillary reflex. And then we have three main layers: superficial, intermediate, and basal. And you will talk about the details then in histology. If I go back to the layers here, if you have injury coming into this layer, then it heals easily. But if it goes through the lamina limitans anterior into the proper substance, it can cause a scar, yeah? Because you rupture the basal lamina of the anterior epithelium, and then it covers, it heals with a scar. Cornea can be transplanted, and it's the easiest transplantation in the body concerning the organs. Well, you should have an idea how thick are the limiting laminae, and as you can see, they are around 10 micrometers. Yeah? They get larger during aging. And in between is the proper substance, which is at least 500 micrometers thick. Yeah, and it's composed of collagen fibers. Of course, there are fibroblasts and immune cells. Yeah, I've talked about that the injury can cause a scar, and the scar can cause a lowered quality of vision, which is called corneal turbidity. So that's all for the layers. As it's more histology. And if you have no questions to the external surface, then we go into the middle layer, or vasculose layer. It's altogether called uvea. So then it's the inflammation, it's called uveitis. And uveitis is also usually autoimmune. Yeah? So it's an autoimmune disease, uveitis. It consists of three layers, or sorry, three parts. The posterior part is called choroid, and the choroid is composed of vessels. That's why vasculose layer. The ventral part also contains vessels, but they contains also muscles, and the function is different than just the blood supply. Yeah? The choroid has to supply the rods and cones. Yeah, so it supplies rods and cones. That's very important. You have problems with the choroid vessels, there is no vision, or the vision is impaired. But for the ciliary body and iris, the function is different, and they contain muscles, so they contract. And the ciliary body has got two functions. Yeah. One of them is contraction, so it is important for the accommodation of the lens, so it changes the length, refraction capacity. And the other function is production of humor aquosus, yeah, of the fluid. And iris, the function of iris is that it works as a camera diaphragm. So it changes the amount of the light coming in, yeah, by meiosis and mydriasis. So that's just generally the function. And now let's talk about the choroid. So the choroid is the posterior part and is composed mainly of vessels. If you try to peel the eyeball as a layers of the onion, so the brown layer of the sclera, yeah, the melanocytes, is also part of the choroid. Yeah, so it stays on the sclera, but it's part of a choroid, so it has got two names, suprachoroid lamina or Lamina Fusca. Then is a small space in between, and then comes the largest layer, which contains majority of the vessels, yeah, and it's called lamina vasculosa, or sometimes choroid stroma. Which vessels we find here? We find here arteriae ciliares posteriores breves, yeah? Short posterior ciliary arteries and their branches. So these we find here. Of course, in between there's some connective tissue, smooth muscle cells, and nerves, posterior ciliary nerves. Then deeper layer contains just capillaries, and these capillaries then supply, as I said, rods and cones. Yes. But the supply and pigmented epithelium, which is the layer of cells which divides choroid from retina, as we show. And the last layer is also a bit strange, as was the first one. I'm sorry. And it's a basal lamina of the pigmented epithelium and the basal lamina of the capillaries and some layers in between. Yeah, which layers I will show you. And as it's a complex structure, it's called a basal complex. And in many books, it's called Bruch's membrane. Yeah, it was described by histologist Bruch as a layer, but then using electron microscopy so that there are more sub-layers. So we have three layers: suprachoroid lamina, then vasculose lamina with big vessels, choroidocapillar lamina with small vessels with capillaries, and then Bruch's membrane or basal complex. So if we go here, we have already seen this, and this is the choroid. Suprachoroid lamina is this. Then you have the vasculose, which is bigger, choriocapillar, which is smaller, and the Bruch's membrane is not well visible in this. Yeah, this is already the pigmented epithelium of retina. Okay, another figure can show you the choroid. Yeah, this is the choroid. This is pigmented epithelium, rods and cones, and then bipolar cells and retinal ganglion cells. Yeah, so this is retina, choroid, and sclera. You can see that the choroid is composed of melanocytes. Yeah, so it's quite dark. So it serves as a dark chamber. So back to complexus. So it's composed of basal lamina of capillaries. It's composed of basal lamina of the pigmented epithelium. Yeah, and then three layers in between. So that's why it's called complex. So the Bruch membrane or basal complex of the choroid. So what is the function of the choroid? I return here. So the function of the choroid is, there are three functions. The first function is to feed rods and cones and the pigmented epithelium, yeah. Of course, there are vessels, so it's the main function. Then there are melanocytes. So the second function is a dark chamber of camera. Yeah, as camera has got also a dark chamber inside, so everything is black. So the light which reflects, which rebounds, is absorbed and does not irritate other cells. Yeah, so that's why there are so many melanocytes, and the melanin prevents the reflection of the light. And the third function, its elasticity retracts ciliary body. We'll talk about the ciliary body in a minute, and I will come to this again. Yeah, it retracts ciliary body to neutral position. So that's the third function of the choroid. Okay. So do you have questions to this? As you can see, these functions are totally different. And sometimes students are lost. They just think choroid is just a layer of vessels. It is. It feeds the rods and cones. And also it contains melanocytes, so it's a dark chamber. And it contains connective tissue, so it has got an elasticity. And it retracts the ciliary body after it relaxes. Yeah? After the muscles, the ciliary muscle relaxes, the choroid retracts it back to its final position, which is usually drawn in figures. So we can talk about the ciliary body now. You can see the ciliary body here. Yeah, there's the ciliary body. There's the neutral position, and the choroid retracts it if it's moved. Well, how does it look? It's again a circular structure. Yeah, so it's a circular structure like many of them in the eye, but on section it looks as a triangle. Yeah, as you can see it here. So it's a ring of a triangular shape on section, and it consists of two parts. One part is this one, and this we call pars plicata, folded part, or corona, as it looks. Yeah, you can look here. It looks as a crown of a king, maybe a bit. And the other part, this one, which is the lateral and dorsal part, is called pars plana, plane. Yeah, and on the section it looks like only like a ring. So there are other names for it. Yeah, so we have a flat or plane part, and we have the folded part or corona. Very important in clinics, as we have an approach, surgical approach. This surgical approach is called pars plana vitrectomy. Well, what does it mean, pars plana vitrectomy? It means that if you need to suck out the vitreous body, which is here in this space, in case there's a blood in, or that it's it is not transparent anymore, there's a turbidity here, yeah, you have to remove it, so you suck it. So you have to go inside, so you go through sclera, and you go through this part of the vitreous body. If you would go more medially, yeah, you can cut these fibers. As you see, these fibers fix lens. Yeah, we call them ciliary zonule. These fibers. Yeah, ciliary zonule. It's like a small forest of bamboos. Yeah, of course, flexible bamboos, but you can think it looks like that. Yeah? So that's why we have to go through this this planar part or flat part, not to cut these fibers which fix the lens. Yeah? And the term pars plana vitrectomy is used in clinic, so now we will understand it, I hope. Okay, the pars plicata has got ciliary processes which are longer and then shorter, which are called folds. Yeah, you can see the processes. The processes serves for insertion of the fibers of the zonule of the fixation apparatus. So the one function is to fix the lens and move the lens. Yes, fix the lens and move the lens. And the other function is to produce the humor aquosus. Yeah. So we have two functions. First function based on the ciliary muscle, which you know, yeah, and we will come to that again, is the accommodation of lens. The other function is production of humor aquosus, intraocular fluid. It's produced from plasma by transudation into the space. So it's produced here in the ciliary body, then it goes into posterior chamber, pupil, anterior chamber, and then it's absorbed to sinus venosus sclera or Schlemm's canal, and then to veins. Yeah, so there's the circulation of the humor aquosus. So back to ciliary body. What is the structure of the ciliary body? So again, on the outer surface of the ciliary body, there's something what corresponds to suprachoroid lamina. That means to lamina fusca of sclera, yeah, the brown layer, and it's called supraciliar lamina. It's quite thin, not very important, but it is a demarcation line between sclera and ciliary body. Then the majority contains, it's a stroma which contains vessels, but mainly the ciliary muscle. And the ciliary muscle is a meshwork of fibers in three planes: circular, radial, and the longitudinal. And longitudinal are in the same plane as the meridianic. That's why also called meridional. Yeah, it is not important to know all these names actively. They are just there. So you should remember that the muscle is not as, maybe you are used to like for example, biceps, which is just running from the shoulder down to the forearm. But it is in three layers, so it's more like in three planes. It's more like tongue, yeah. It's a composition of the fibers. Of course, it's smooth one. It's innervated by parasympathetic, so it's brought by oculomotor nerve, and the function is accommodation. How the accommodation works? If the muscle is contracted, the ciliary body moves this way. So it moves medially and dorsally. I return to this figure and explain it here. So the ciliary body, which is here, moves here dorsally. So what happens to ciliary zonule? It is not tightened anymore, it is relaxed. When it's relaxed, what happens with the lens? Then the lens can enlarge. And when it enlarges, it changes the refraction of the light rays, and you focus on near objects. Yeah. So you focus. If you decide to quit this and you would like to focus on distant object, what do? You relax the muscle So if you relax the muscle goes back. What happens with the fibers? The zonular fibers are tightened. What happens with the lens? The lens is flattened. That means the light rays are going like this, and you look at distant. Yeah? And this retraction is done by relaxation of ciliary muscle and by traction of the choroid back. Yes, by the elasticity. So you understand this? Question, why does the corpus ciliary move backwards when it contracts? It's because of the shape of the fibers. The shape of the fibers altogether moves it this way. Yeah, that's why I told you it's a complicated meshwork, and we do not go into details of the fibers, but it is like that. If it contracts, it moves this way. Yeah, it's a circle which contracts, so it gets like this, and it moves dorsally a bit, dorsally and medially. Yeah, okay. So I hope you understand this, and we can move to further detailed structure of ciliary body. So what else we have there? So when we get in, yeah, this is the stroma with the vessels, here is the muscle somewhere. And when we continue to the inner surface, we have again something which is similar to choroid, the Bruch's membrane. But in this area, it's very, very simple. It's just basal lamina. Yeah. So basal lamina here. And then on basal lamina, we have epithelium. The epithelium has got a pigmented layer. Yeah. It's a continuation of the pigmented layer of retina. And then we have a non-pigmented layer. It's continuation of the sensory epithelium of retina. That means rods and cones. But in this area are no rods and cones. Yeah, this is a blind part of retina, no vision. So it's replaced just by simple cuboid epithelium, non-pigmented epithelium. And in between is a canal, which is usually not drawn, but it's in between, ciliary canal, and to this canal is via transudation produced the humor aquosus. Yeah? So the humor is produced from the vessels in stroma through the basal lamina and the pigmented epithelium into the ciliary canal, and then through the slits between the cells into the spaces between the zonulary fibers, and then to posterior chamber. Yeah? And on the very surface, we have limiting internal lamina of retina, which is then the basal lamina of the Müller cells. We will talk about this later. And that's the very surface. Yeah. Any question to this? It's again more histology than anatomy, but you can see that it is good that when we skip the topics a bit, as you should think about the eye as an organ. Yeah, we are not able to distinguish what is anatomy and histology here. So for using some histological slide to show, this part is the pars plicata, this part is the pars plana, and on the surface you can see the pigmented epithelium nicely, and the non-pigmented epithelium. This is vitreous body, and on the surface of the vitreous body there's a membrane. Yeah? And from the ciliary canal, which is between the pigmented and non-pigmented epithelium, the humor aquosus is produced here, to the posterior chamber, pupil, anterior chamber, and to sinus venosus sclera or Schlemm's canal. Yeah? Some other figure, again showing the ciliary body, yeah, with the pigmented epithelium and then non-pigmented epithelium. This is ciliary zonule. Yeah. This is retina and lens. On lens, you can see this layer. It's epithelium, then a capsule. We will come to that later. And you can see that if we go dorsally, then the cells are dispersed inside lens, and the lens is formed by these. This is one cell, yeah, going like this. This is still one cell, this fiber. In this area, we find the ciliary muscle and the stroma. And this is already iris. And we are going to talk about the iris right now. So what is iris? Iris, and I'll come back to maybe this figure, nicely visible. Iris is the continuation of the choroid and ciliary body ventrally. Yeah? And it forms pupil here. So you can see that uvea, or the vasculose tunica, the vasculose layer, is a continuation of three structures: choroid, ciliary body, and iris. Iris and ciliary body are, of course, circular structures. Yeah. So again, it's circular, but you can nicely see it because anterior surface of iris is well visible if you look into someone's eyes. Yeah. It's very flat, as we have seen. So it's flat, non-transparent annular ring. The diameter is like 2 centimeters approximately. What is the function? It forms this opening which interconnects anterior and posterior chamber and allows the light to go in, and it works as a diaphragm of a camera, so it can be reduced in meiosis or enlarged in mydriasis. Yeah? So it works in pupillary reflex. For these two functions, there are two muscles. I'll come to them. And to describe it, we have two margins: the internal margin, which we call pupillary margin, and the outer one, which we call ciliary margin. Yeah. There are two annuli. The major annulus and minor or lesser annulus. And they contain arterial rings, as you can see here and here. Yeah. The major and so the greater and lesser arterial ring of iris are here, just to supply it. So you should know approximately how the pupil can, what is the dimension of the pupil, from 2.5 millimeters up to 7 millimeters, depending on meiosis or mydriasis. Yeah? On the anterior surface, that's very interesting. The anterior surface, there is no epithelium there. That's why you can nicely see the contour. Yeah, if you look at it, and you can see these openings, and these openings are called cryptae. Yeah, and in between the greater and lesser ring, there's these toothy line. And this toothy line is called collaret in English and catella in Latin. Yeah. And this opening during embryology was closed with a membrane, The membrane is called pupillary membrane. Then this membrane ruptures, yeah, by apoptosis, and this is just the remnant. So the collarette, which is nicely visible in the eyes, is the remnant of the attachment line of the pupillary membrane. Okay, so now let's go to the layers. Before the layers, of course, the muscles you already know, the sphincter for meiosis, and it is governed by oculomotor nerve, nucleus, the Edinger-Westphal, and the dilator in English, dilatator in Latin. Yeah, there's a difference between these, governed by sympathetic nucleus in articular formation at the level of C8, yeah, in the ciliospinal center, and it performs mydriasis. But this is what you already know. The anatomical or histological difference is well visible here. The dilator muscle forms only a layer, yeah, a thin layer, quite dorsally. The sphincter forms such dispersed bundles, yeah, inside the stroma. So that's the anatomical difference between these two, or histological difference between these two muscles. So now if you go to the layers, we start ventrally, and as I said, ventrally is no epithelium. It's covered only by transformed or modified cells of the stroma. So it's just called stratum limitans anterius, and there are many crypts visible. And these crypts also serve for absorption of the humor aquosus. So the aqueous humor is absorbed not only into veins, but partially, but only in small extent into the vessels of iris. Then this termination of the pigmented epithelium is called pigment frill or pupillary ruff. Yeah, no Latin name for this. And it can be also visible if you look into the eyes. Then we have stroma. And what is in stroma? In the stroma we have mainly the muscle, sphincter, yeah, as you can see the sphincter, for example, here. And the dilator is not here. The dilator is part of the posterior epithelium, yeah, so the dilator is this layer. And the posterior epithelium, which is here present, contains the dilator. And the dilator are myoepithelial cells. Yeah, so it's a specific kind of a muscle. It forms the myoepithelial cells, and it's derived from neuroectoderm. And then the very posterior layer is continuation of the pigmented layer of ciliary body, so it's the pigmentous layer. Yeah? So both ciliary body and iris are covered with pigmentous and non-pigmentous epithelium or layer, but they are opposed. Yeah, in iris, the posterior most layer is the pigmented. In ciliary body, the most posterior is non-pigmented. Yeah, so this is an important histological difference between these two. And a stroma, which I have skipped, it contains also vessels. So there are like two layers. The anterior is without, there are just small vessels. In the posterior layer, there are bigger vessels, the arterial circles. Okay, question to this? If not, we have just the lens and vitreous body before the break. So what is a lens? Lens is a specific structure, and it's again like cornea, transparent. It's big convex, not like erythrocyte, which is big concave, and of course avascular, so the light can go through. So it's again fed by diffusion from humor aquosus. The function, it's obvious. When it flattens, you look at distant object, you focus on distant object. If it's enlarged, then you focus on the near object. Yes, yeah. So you look at near. We have said that cornea, as it does not change its shape, its optical or refractive power is 43 diopters. The lens changes its shape, so the number of the diopters also changes. So it's from 15 to 20 approximately. To describe some structures, we have anterior and posterior surface, we have anterior posterior pole. Yeah, so the poles are here, and the surfaces are also obvious. We have an equator. Yeah. So another color, we have the equator, and equator is here. Of course, axis is here. Yes, not a problem. It's formed, as I said, by cells. You can see the cells. And from the cell, this is the body of the cell, and then the cells and their bodies continue farther. So they form such fibers, yeah? The term fibers is used. And the fibers start and terminate at sutures, and these sutures are called the radii. You will talk more about these in histology then. And the radii can be visible during the examination on the lens. Ciliary zonule of Zinn, you know this eponym from Montaigne-Nose ring, is this area, yeah? And it's the fixation or suspension apparatus of the lens. Well, the most common disease of the eye or severe is called cataract. What happens? It is not opaque, and especially in older age, it changes into a white structure. Yeah. So what you need to do is to replace it. So we cut the capsule here. With the ultrasound, we destroy the contents, we suck it out, and we put inside an artificial lens. And as a lens is, the term for lens in Greek is phakos, yeah, in Greek. So then pseudophakia means an artificial lens, yeah. Okay, what are the layers? So I said we have an epithelium, and you can see it's a simple cuboid epithelium, yeah, well visible here. But on the surface is capsula, and this capsula is very important. That into the capsula, yeah, which is this layer on the surface, the fibers of the zonule are attached. So if you would like to remove it, you have to remove and replace the cataract lens. So the substantia, which is here, is sucked out, but you have to keep the capsula in the position, yeah, and then you put into the capsula the new artificial lens. If you would destroy the fibers or the capsule, then the lens cannot be put there. Yes. As for the substance, this is more histology. We will talk about this, and you should have an idea that the thickness is around 4 millimeters and the diameter is around like 1 centimeter. Yeah. It contains quite much of water, and in diabetes, when the level of glucose goes up, then it can get swollen and it can start the cataract. That's why people with diabetes suffer from cataract. Yeah, so here you can see how it's arranged, the capsule, the anterior epithelium, and then the continuation of the cells inside. And as I said, it's histology. So we continue. We have talked about the focusing. So do you have any question about that? If you would like to focus what you do, you contract the ciliary muscle, the ciliary zone will relax, the lens is enlarged, and you focus on near object. Yeah, you look at near. And of course, if you look at near, you converge and you contract the sphincter of pupilla, so you perform meiosis. If you decide to look at distant, then the ciliary muscle relaxes, the lens is flattened by the basic tone of the choroid, yeah, which retracts it back by its elasticity. And of course, hemidriasis is performed by the dilator muscle in iris. And now the last information is the vitreous body. So the vitreous body is a jelly-like structure which is located behind lens. Yeah, it fills the majority of the space. So it's we have quite large amount of it, but the large amount means 40 milliliters. So it's 10 times more than the volume of humor aquosus. It's mainly composed of water, but not only water, there's a hyaluronic acid, that's why it's a jelly. Yeah? It's produced by cells, hyalocytes, only during prenatal time. Yeah, so it does not regenerate, very important. So in case there's an injury, it has to be replaced. So we put in some oil, or a balloon can be given there, or an air, and it's then slowly replaced by your own humor aquosus, and then the oil is taken away, yeah, or the fluid is taken away. So please remember that. Why we have the vitreous body? When I go maybe back here, you can see it's not well visible here. I'll find a nice figure for that. But the pigmented epithelium, yeah, it's well visible here. The pigmented epithelium and retina, they are not attached firmly. Yeah, so even here, this is the blind part of retina, but this area here, the pigmented epithelium and retina, they are just lying one layer on the other layer. And the function of vitreous body is to not compress it, but just to keep it, just to maintain the position of the retina on pigmented epithelium. Yeah, if it's away, then the detachment appears, and you can see there's also some detachment after histological processing of the slide. So you can see the surface, which is called membranous, a vitreous membrane, and it's detached, and the retina will detach as well. So that's important for clinics. The loss of vitreous body can cause detachment of retina and blindness. Yes. Inside the vitreous body, if the body looks, yeah, the body maybe can be like that, and then we have the space for lens. Yeah, the lens would be here. So what is here during development? A vessel which comes from the central retinal artery, and it's called the hyaloid artery. And it supplies the lens during the development. We know that the lens comes from the optic or lens placoid, so it's a surface ectodermal structure. Yeah, and it's supplied by hyaloid artery coming through the hyaloid canal. I here underline the fossa. The fossa is this, yeah. The fossa is the impression of the lens. So important is the volume, and important is the function, that it maintains the internal eyeball pressure, and after lost retinal detachment in Latin amotio can happen. Yeah. So this is the function of the vitreous body. And we have talked about the humor aquosus repetitively. So what it is, it's a fluid, and its volume is only 0.2, 0.3, or 4 millimeters. The daily production is 10 times more. As you can see, the composition is similar to more to water than the plasma. So the number of the minerals is quite low, and of course the number of glucose and urea is low. No protein, so it's just a fluid. Yeah, substitute lymph. It's produced in ciliary body, absorbed in iridocorneal angle. We have talked about that. I will show you the iridocorneal angle again. Very important is the normal intraocular pressure, less than 20 millimeters of mercury. Yeah, if it's elevated, it compresses retina and it kills the cells. Yeah, and it's called glaucoma. So very important is if the intraocular pressure is higher. So it's also one of the basic examination is to examine the intraocular pressure. So how the humor aquosus circulate? For that we need to talk about the chambers, but we already know the chambers. This is the anterior chamber, yeah, between cornea and iris. That's the anterior chamber. Then we have posterior chamber between iris, ciliary body, and lens. So this is the posterior chamber. What interconnects them is pupil, which is here, yeah. So that's natural connection. And then of course we have the postremal or vitreous chamber, which is here, contains the vitreous body. And as we said, the humor aquosus is produced by ciliary body, flows through posterior chamber, pupil, anterior chamber here into structure which is called iridocorneal angle. Now let's come to the iridocorneal angle. Here again the chambers, yeah, the anterior chamber, the posterior chamber, and the vitreous one. This is ciliary body, iris, retina, pigmented epithelium, and you can see the detachment after histological processing, and this detachment can happen when the vitreous body is not here. Yeah, so then it would detach this way as well. Of course, lens, and this is palpebra. Yeah, and cornea. And we are going to talk about the iridocorneal angle, which is here. So the iridocorneal angle is also visible here. And what is it? So iridocorneal angle is between iris and cornea. And that's the place where we find the trabecular network. That means the reticulum trabeculare, or pectinate ligament, or fontana spaces. And then the humor aquosus is produced in ciliary body, flows to posterior chamber, pupil, anterior chamber, iridocorneal angle, fontana spaces, Schlemm's canal, and through the veins of sclera farther away. Yeah. So this is very important. And if we move the ciliary body, if we move it during the contraction of ciliary muscle. So during accommodation here, then it's fine. But when it gets back, it compresses the angle, it compresses this area, and it can block the drainage. Yeah? It can block the drainage of the humor aquosus here. And we know that the function of the ciliary body is done by parasympathetic system. So if you use parasympatholytic drugs, that means the parasympatholytic drugs will do what? They will move it back here, so they will compress it here. So parasympatholytic drugs will worsen the drainage. So in case of a glaucomatic patient, the patient with diagnosis of glaucoma, do not administer parasympatholytic drugs, otherwise the glaucoma will be very worsened, and the patient can suffer from a glaucoma crisis and can feel a terrible pain in the eye. So this is pharmacology based on anatomy. Yeah. So again, a figure just to show you what I have repeated several times: the flow of humor aquosus into cerebro-iridocorneal angle, trabecular meshwork, Schlemm's canal, and then to veins. Yeah. So a figure for homework, and then the way of the here you have all the spaces through which the humor aquosus is drained. Okay? So you can be asked about this in the test or orally. Yeah, very important. If it's blocked somewhere, it causes higher intraocular pressure and glaucoma. That means glaucoma can result in blindness. And to close this first session, we have an optic coherent tomograph. It works as a computer tomography, but it does not use the X-ray, it uses an optic ray. And the optic ray reflects on different surfaces, and it can nicely show both the anterior and posterior segment of the eye. So you can see here the iridocorneal angle, yeah, or you can see the epithelium of the cornea as well. So it's now a basic examination tool, OCT, optic coherent tomograph. Yeah? Questions? Recording. We continue to talk about the internal layer of the eyeball, which is also called nervous layer, and also retina. Yeah. So this is a very homogeneous layer. No subtypes. Or the subtype is here, covering ciliary body and iris. Yeah. So we have this part which is reused only into the pigmented layer and non-pigmented layer, as we have talked about this. And we call it a blind part or pars sicca. Yeah, it's very reduced, thin, and it's in the areas where the light could not come here and could not then cause the light. That's why it's reduced. The border with the optic part is toothy-like, so it's called ora serrata. Serra is a saw, so saw-like or toothy-like. Yeah, and then we have the optic part, and the optic part is composed of the unilayered pigmented epithelium. So one layer of the cuboidal pigmented cells, and then another layers forming the sensory part. So if we talk about the pigmented part, yeah, and I don't go into detail as this is histology, I just give you the main information. So the pigmented layer is a simple cuboid epithelium, yeah. Its basal lamina is part of the Bruch complex membrane. As we said, it's a basal lamina of the capillaries of the pigmented cells and some layers in between, yeah. And what is the main function is the nutrition of rods and cones. So these are like nerve cells, so something like Sertoli cells in testis or astrocytes for neurons, yeah? So it's a nutrition, it's a resynthesizing of photopigments of rods and cones and degradation of their membranous discs, and they also work as a barrier blood retina, yeah? Like so Sertoli cells work as a barrier blood testis, yeah? So this is just the main function and information, and the rest in histology. And you can nicely see them here as they are filled with melanin granules. Yeah, these are rods and cones. And this is the pigmented layer. And this is the Bruch's complex or membrane. And of course, choroid, yeah, in here. As you can see, also the choroid contains the melanocytes as well, yeah, and as it serves as the dark chamber. Then the other layer, the sensory part. It is composed of rods and cones, so the first order neurons of the optic tract, bipolar cells and retinal ganglionic cells, so the second order and third order neurons of the optic pathway. Then some interneurons, which we call association neurons, horizontal and amacrine. And of course, some glia, supporting cells or nerve cells, and we call them Miller cells. And these Miller cells go through the whole thickness of retina like that. Yeah, they have the body, and they go through the whole thickness. Whole thickness. Okay. So if you look here, the pigmented layer, and then the retina itself, the sensory part is this, with the rods and cones, and bipolar cells, and retinal ganglion cells. Then this we call outer segments of rods and cones, yeah. And then these we call new plexiform layers. And you can see that the plexiform layers contain dendrites of the deeper layer and, axons of the deeper layer and dendrites of the superficial layer. And then this contains the axons of ganglionic cells. So this then forms the layers of retina. I don't talk about the rods and cones and bipolar retinal cells, horizontal amacrine cells, and Miller cells as its histology. We will talk about that in histology part. And we have altogether 10 layers. Yeah? So we have 10 layers, and the 10 layers are done by the positions of the cells. Yeah. So we have the pigmented epithelium, and we have the outer segments and inner segments of the rods and cones, and we have the bipolar cells and retinal ganglionic cells, and then we have the layers which are in between, the plexiform layers with dendrites and axons. So altogether then you can get 10 layers here. So they are listed here. Go through them in histology at home. You should know their names as they are visible on OCT. Yeah, you can see here that even the OCT shows more layers than are visible, the more layers than are histologically distinguished. Yeah, as these layers then show some sublayers, and the whole eyeball OCT has got 18 visible and described layers. Yeah, so you can see that even you can think that why we should know about the layers. The answer is we can all see them, and maybe we can see more than in histology, in classical histology are described. You can see them on OCT, and that's why we should understand them. I will show you the OCT. So then you can see the layers here, you can study them at home, and of course on histology specimens. From the macroscopic point of view, we should talk about two specific parts of the sensory part of retina. And one of them is called optic disc. The optic disc is well visible here, and is the area where the optic nerve exits. Yeah? If you look into the eye like ophthalmoscopy or fundoscopy, then you see the optic disc here. The optic disc has got an excavation, which is called optic cup also, and the optic cup is this area. And it has got a margin, which is called Sclera Annulus, and the margin is this one, the Sclera Annulus. Yeah, and we have talked about that at the beginning. The Sclera Annulus is this structure. So it's not only the exit of optic nerve, but it's also entrance of the central retinal artery and vein. And you can see the branching of them here, and I'll come to the branching in some minutes. Yes? So it's an entrance of central retinal veins, it's exit of the optic nerve. It has got a cup or excavation in the center, and it's called optic disc sometimes, and the colloquial name is blind spot. In clinics, it's sometimes called papilla. Yeah, but papilla is usually meant as a swollen disc during intracranial pressure. Higher, raised intracranial pressure. Histologically, we can see it here. This is the cup or the excavation. You can see the detachment after histological process. Yeah, the sensory part is detached from pigmented epithelium. You can see nicely optic nerve, central retinal vessels, and the optic nerve has got the covers of the brain. As we know, optic nerve is not a nerve, it's a pouch of diencephalon, so it's covered by dura mater and leptomenics as well, the pia mater and arachnoid, they are fused. So the fluid, the subarachnoidal fluid can come here and can cause a bulging here. So in case of raised intracranial pressure, there's a bulging, and you saw it as a bulging papilla. Yeah, I'll show you later a figure of that. Yeah, here is well visible the detachment, the histological processing detachment of sensory part of retina. Yeah, rods and cones, bipolar and ganglionic cells. These are the axons of ganglionic cells forming the optic nerve. Yeah, and this detachment, of course, can happen during the pathological state as well. The other important landmark here is called macula lutea, or colloquially yellow spot. Yeah? We can see it's located laterally to the blind spot or to the optic disc. It is important, as you can see here, that the more superficial layers are deflected laterally. So then the light can easily come directly to rods and cones, and in the center into cones only. Yeah. So there is no loss of photons. All the photons come here, so it's the place of the most acute vision. And of course, we can distinguish some parts. So the very center is called umbo. Umbo means umbilicus and navel. So there are only cones and the nursing cells, so the Miller cells. Yeah. Then we have foveola, where we find already the bipolar cells and some other association ones. Then we have the fovea. As you can see, there are no rods in these areas. Yeah. And then you come to para-perifovea and the borders of the macula itself. Yeah. And the whole macula as you can see, is 0.5 centimeter big circular structure. Yeah. So very important. If there exists something which is called macular degeneration. And it's usually called age-related macular degeneration, and it comes in older age, and it means new blood formation, so angiogenesis in this area. And what then happened is so-called central scotoma. Yeah, so it causes central scotoma. Central scotoma means no vision in the center of the vision field, so where you just focus. So it's a very unpleasant state and disease for older people. And histological section just to show you the area of macula. Yeah, and you can see in the center we are not just in the umbo, as there are some bipolar cells, so we are in foveola here. Well, and if you look at the OCT of the posterior segment, you can see nicely here the structures. So the optic disc in the area of the optic, the optic cup in the area of the optic disc. Yeah, this is the area of macula lutea, yeah, and the different layers which are visible here. If we continue to other figures, here nicely you can see all the layers visible, so you can go through that at home. As you can see, the layers of bipolar cells, ganglionic cells, and rods and cones, yeah, and their dendrite axonal interconnections as the plexiform layers and the area of macula. Right? So that's why you should know all the layers. For example, here even you can see nicely the pigmented layer. Yeah. So OCT gives you a nice overview, and what we can see here is the detachment of retina, and the detachment is well visible here as it's undermined here. So there's a real detachment of the retina causing focal blindness here. Yeah, so that's why OCT very important. Okay, that's all for retina. You will go in details in retina in histology. So that was an introduction. And now blood supply of the eye. Nothing new for you, as we have already studied the blood supply. So it branches from ophthalmic artery, and we have posterior ciliary arteries, short, as we have talked about that, forming the choroid and supplying rods and cones and pigmented epithelium, and then long, and the long they travel ventrally to the anterior segment to supply ciliary body and iris. But ciliary body and iris, they also get recurrent anterior ciliary arteries. How they get there? They get there from muscular branches. Yeah. Let's look here. How they get there. So we have posterior ciliary short arteries. Yeah, so these are short. This is long one, and if you follow the long one, it goes here ventrally to iris and ciliary body. And then we have these ones, these ones, muscular, supplying muscles, and continuing here to supply the iris and ciliary body. So these are called anterior ciliary arteries, yeah, and these two are posterior ciliary, short and long. They of course gives branches to episcleral area, so we have some episcleral one, and then here to the conjunctiva, so some conjunctive branches. Yeah, so for the blood supply, anterior ciliary branches, episcleral and conjunctival branches coming from the muscular one. And what is a bit new is the central retinal artery. You know it exists, but it supplies retina, but no rods and cones. Yeah, rods and cones not, as rods and cones are supplied by the short ones. Yes. And the branches of central retinal artery I'm going to show you now. This is just the macroscopy, so I can highlight here some of the arteries. So we have the ophthalmic artery here, giving the central retina, yeah, entering the optic nerve. We have the lacrimal here. We have the posterior ethmoidal and anterior ethmoidal here. We have the supraorbital. And for the eyeball, the most important are these, which are the posterior ciliary long and short, entering the eyeball. Yes. And we have already shown this, so I can highlight the central retinal artery coming and supplying the more internal layers of retina, so not rods and cones. Yeah. So it can be also shown on the section. Central retinal artery, yeah, entering at the optic disc and supplying the bipolar and retinal ganglionic cells. Short posterior ciliary artery supplying rods and cones. Long ones supplying ciliary body and iris. Anterior ciliary as branches of the muscular ones. And also supplying conjunctiva. Yeah, more figures for your home study. And a figure which you should know how to draw. This is the ophthalmoscopic or fundoscopic view. Yeah, now you look into the right eye, and you can see the optic disc and macula lucea. And you can see the branching. The branches are arterioles. They are very small. Yeah, they are less than 100 micrometers, so they are small, but they are fine. So hypertension and diabetes, which are the angiopathic diseases, so you can see their symptoms already on the fundus of the eyeball quite soon. Yeah. So if you look into the eye, you can see some of these important diseases. So the branching is then superior inferior temporal, superior inferior nasal, and superior inferior macular. There can be sometimes middle macular. Okay. Veins, the same as the arteries, they often cross them. And which diseases you can detect here is hypertension, diabetes. It's on vessels, and raised intracranial pressure. And the raised intracranial pressure you of course see not on vessels, but on the enlarged, swollen optic, other color, optic disc. Yeah, I will show you at the end how it looks like. So please learn this figure, how to draw it, because every physician should examine the fundus of the eyeball, yeah, so ophthalmoscopy. Okay, from the anatomical and clinical point of view, there's one important variant. It's called cilioretinal artery. Okay, what you should know. It's present in 1/5 to 1/4 of patients. Yeah? Cilioretinal means it's a branch from posterior short ciliar artery, but it does not supply rods and cones, but it supplies the majority of the retina. So it supplies the same area as the central retinal artery, but it enters separately from it. Yeah? So you can find it separately from the central retinal artery. So it's an additional blood supply to macula. So what can happen? If this artery is closed, you can have a central scotoma. Yeah? If the small artery is closed, you can have a central scotoma. But if the whole central retinal artery is closed, the cilioretinal artery is not branched from central retinal, but it comes from different area, from posterior ciliary short arteries. So it saves the vision. Yeah? And you have not affected macula and you have spared central vision. So this artery can save your vision in case of closure of central retinal artery. Now to show you how it runs, and this artery is usually missing in anatomical books. So you can see it's a branch from short posterior ciliary artery. It enters the optic disc and it comes here to supply the macula lutea. Yeah, so we can see it here as it enters the optic disc, but separately from central retinal artery, and it then continues to supply the macula. As you can see here, it continues to supply the macula and can spare the central vision in closure of the central retinal artery. Yes, so that's cilioretinal artery. Please remember that, even it's a variation. Of course, questions you can pose me here. If everything is clear, veins. Veins similar to arteries. There is only two differences. One difference is this, varicose veins. These varicose veins, I better show you on a figure. When I come back to arteries, you can see here the varicose veins. Yeah. So the varicose veins, there are 4 of them in each quadrant of the eyeball. So we have 2 inferior medial lateral and 2 superior medial lateral, and they drain the area of short posterior ciliary arteries. So there are no short posterior ciliary veins, yes, because the arteries, as you can see here, they enter from dorsally, supply the choroid, but then the veins exit in a quadrant, yeah, in a different way, and they are called vortex veins. So that's one difference. Yeah. No short posterior ciliary vein, but are replaced by varicose veins. And then the drainage goes into 3 directions. Either, and it's in less extent outside, so into angular vein and facial vein and internal jugular vein finally, or inside the skull. Superior ophthalmic vein through superior ophthalmic fissure to cavernous sinus, and internal jugular vein, of course, and via inferior ophthalmic vein through inferior ophthalmic fissure into infratemporal fossa to pterygoid plexus and internal jugular vein. So why we are going to talk about that it can spread from face into the eye. Yeah, that's one information, that an information from the face can spread into the eye and then farther into cavernous sinus. The second, it can serve as an emissary vein. So the blood from cavernous sinus can be pressed into the eye and then outside to the face. Yeah, in some cases of venous hypertension in dural venous sinuses. So please remember these 2 important things.
And we can see it here on a figure. So superior ophthalmic vein to cavernous sinus, inferior orbital vein to pterygoid plexus, and angular vein, facial vein. Yeah. I think there is nothing tricky, so we can move to lymph drainage. Inside the eye, there is no lymph. The lymph is only within the orbit, and it's very fine networks with no specific names, so we do not talk about that. But please remember, inside the eye, no lymph, but also inside the orbit, where is normal muscular tissue and adipose tissue, there is of course lymph. Okay, what about the innervation? All this you know, just quick review of the information. Of course, the eye is a special sensory organ, so here we have optic nerve. All the area is supplied somatosensory by the first branch of the trigeminal nerve, yeah. Inside the eye, it's long ciliary nerves. Outside the eye, the nerves, you know, lacrimal frontal, which go outside the common tendinous ring, and nasociliary, which goes inside. To move the muscles which are outside, so the extraocular muscles, we have oculomotor, trochlear, and abducent. To move the muscles in, ciliary, sphincter, and dilator, we have sympathetic and parasympathetic fibers using ganglion ciliare and short ciliary nerves. Yeah, all this you know. Again, nothing new and tricky. Just to show you the nerves here. So we have the frontal and lacrimal and nasociliary nerves, which are branches from ophthalmic, the same these, long ciliary supplying the eyeball, yeah, as you can see it enters the eyeball here. So these come from the ophthalmic. Then we have trochlear, with all together with lacrimal and frontal go outside the ring. And then we have the abducent and oculomotor. Yeah, you can see the upper branch here and the lower branch here. So all these go through the common tendinous ring. And then we have the ciliary ganglion here and the short ciliary nerves entering the eyeball to supply the smooth muscles. Okay? And of course, optic nerve down here, the thick one. I think there's no question to the nerves, just a revision. Okay, visual pathway. Questions to the visual pathway. We have talked about the visual pathway in CNS pathways. So I go very, very quickly through that. If you have questions, you can post them. First three neurons are layers of retina. Yeah, rods cones, bipolar retinal ganglionic cells. Their axons continue as the optic nerve, partially crossed in chiasma, and ending in lateral geniculate body nucleus, interpolated and continuing as the optic radiation or geniculocalcarine fibers. These are synonyms to area 17 in occipital lobe around calcarine groove. They continue as three loops. The loops are visible here well. And what about what we should know about the loops? We have a central fascicle or loop, nothing interesting. We have the posterior loop, which is sometimes called Baum's loop, but it also goes directly through parietal lobe. Yeah? And then we have the inferior loop, or anterior fascicle. You can see the fascicle here. And you can see as it winds around the inferior or temporal horn of a lateral ventricle. Yeah, that's the horn of the ventricle, and it goes around. Here again, it's well visible. So if you have a pathological process within the anterior part of the temporal lobe, yeah, so somewhere here, it can compress the flexic Meyer-Archimboldt loop or the anterior fascicle or lower loop, and it can cause problems. Where? It's inferior loop, so in inferior half of the retina. But don't forget that the lens reflected or changes the direction, so it comes from the upper half of the visual field. Yeah, it's due to the lens reversion. So if you have problems down in the tract, you have problems up in the visual field. Yes. How the problems looks like? The problems looks like quadranopsia. So if you look here and we have problems, it's drawn here. Yeah, in Meyer's loop or flexic Meyer-Archimboldt loop, the inferior loop, the anterior fascicle, then the problem is in the inferior part of the loop, inferior part of the retina, but superior part of the vision field. And it's only quadranopsia, yeah, it's part of the pathway, and it's homonymous, it's the same on both eyes. Of course, if you cut the whole optic radiation, you have hemianopsia. Why there is this central sparing? It's because of fibers of macula lutea, which are here. These fibers are both decussated and non-decussated. That's why if you cut it on one side, still the other side will bring information. So you have these central sparing. Yeah. In case there's a tumor of hypophysis here, it then compresses the medial parts of retina. That means lateral parts of visual field. That's why this number 3 is different from the others. So you have not homonymous, but heteronymous hemianopsia, different in both eyes, and it's bitemporal. So you can see what is here, but not what is on the side. So if playing football, you do not see a ball passing from the side, you just see the goalkeeper. Yeah. Okay. What is this? It's a problem in macula, and I already call it age-related macular degeneration, which is the most common disease causing this central scotoma. Yeah, so the problems in the eye. But you can have also the same here on both sides if there's a tumor close to calcarine groove. Yeah, so it can cause this. So it's again a central scotoma, but bilateral. Okay, that's for the problems, disorders. And then we have some visual pathways, collaterals. So from the third neuron, directly, third order neuron, directly from the retinal ganglion cells, information goes to suprachiasmatic nucleus. And the suprachiasmatic nucleus is the nucleus which is a center of circadian rhythm. Yeah, the circadian rhythm is the rhythm approximately 24 hours. And the rhythm affects, for example, the melatonin secretion in pineal gland, but also it affects the alternating of the levels of some hormones like cortisol. Yeah? So it gets information from here. If you have patients who's got problems with this area, or if you would like to travel across the world, so again, jet lag, what you do, you start to shine the light into your eyes, so the suprachiasmatic nucleus is irritated, and then it can cause the lower level of melatonin and a higher level of cortisol, and you are awake. Another collateral goes to pretectal area, and we know that the pretectal area is the seat of pupillary reflex, And pupillary reflex means if we shine into the light and we need to perform the meiosis, and for the meiosis we use the oculomotor nerve, the parasympathetic fibers, and it's interpolated in ciliary ganglion, and it goes to sphincter pupillae, and of course to ciliaris that you accommodate. Yeah, and for meiosis, you need to use the sympathetic pathway. So the sympathetic pathway uses particular formation, has to go down to level of C8, where is the ciliospinal center. And from this, it can use the wide communicating branch and then go up to superior cervical ganglion when it's synapsed, and it goes up to ciliary ganglion not synapsed, and finally to the later muscle for mydriasis. If you use the eyes, you converge and diverge, and you coordinate the movements of the eyes, head and neck. That's why you need the collaterals into the Kachlík nucleus and into tectum. Yeah. I think we have talked about these already in CNS, so it's just a revision. And we can continue to accessory visual organs. That means outside the eyeball. So if you have questions to the eyeball, you can ask. If not, we are going to talk about these accessory visual organs. One of them is supercilium. Yeah, supercilium, just the hairs which are above the eye, yeah, which can protect the eye a bit. Then we have some fibrous or ligamentous structures, some fascia, we have some muscles, you already know them. We have the eyelids, which are covered by conjunctiva from internal surface, and of course we have lacrimal gland and the excretory lacrimal system. So the easiest is the ligamentous apparatus. Periorbit is the name of the periosteum here. And the periorbit covers the inferior orbital fissure. Yeah. So we have fissura orbitalis inferior, which is covered by a membrane, and this membrane contains smooth muscle cells, which are known as orbitalis muscle. Yeah. Then another fascia, or a ligamentous structure, but this is a real fascia, is the bulbar sheathus, so the vagina of the bulbus. And we have already talked about that the vagina is like a fossa of a joint. Yeah? And the vagina is around, so we can see the vagina here. Yeah? In between the eyeball, and the vagina, we find the episcleral lamina, which allows the movements, and it's fixed to the roof by so-called suspensory ligament. Yeah, otherwise it would fall down. So we have some short suspensory ligament. We do not see this ligament dissections as we dissect. We approach the orbit from above and we destroy it. Septum orbitale, we said, is a frontally oriented plate which not allows the eyeball to protrude. Then we have a fat pet, corpus adiposum orbite, which fills the space mainly behind the eyeball. And of course, muscles has got its fascia. Yeah, episcleral space is the episcleral lamina here, loose connective tissue. Okay, another structure is conjunctiva. The conjunctiva is well visible on this figure. As you can see, it covers the eyelid, all palpebra, which is here. It's covered by skin, there are eyelashes, and then the internal surface is covered by conjunctiva, and then the conjunctiva gets onto sclera. And if you look into the eyes, you see the white part of the eye as the sclera covered with conjunctiva. So we have the conjunctiva of the bulb and we have the conjunctiva of the eyelid. Then this area is called sac. Yeah. In English, it's called conjunctival sac. In Latin, it's called superior inferior fornix. That's the area where the palpebral conjunctiva changes into the bulbar one. Of course, the question is, what is the conjunctiva? Yeah? And it's a epithelium. It's similar to skin and cornea as it's between, so it's stratified epithelium, it's non-keratinizing epithelium, and the height of the cells, as you can see from the histological slide, is different from low cuboid to high columnar. Yeah? It contains not only the keratinocytes, but also some goblet cells, lymphocytes, melanocytes, and below we can find the lymphoid nodules. Yeah? So it's similar like in GIT when we have the gut-associated lymphoid tissue. Here we have the conjunctiva-associated lymphoid tissue. And that's in case we have an allergic reaction, then we have problems in the eyes. We have a conjunctivitis, and it is repetitive. It gets chronic because we have these big lymph noduli there. Not big, but they can get bigger during the chronic inflammation, during the chronic allergic reactions. Yeah? Okay, in between these two parts of conjunctiva and in between the cornea and the conjunctiva, so here, it's filled with tears and we call it lacrimal film. And the lacrimal film is produced by lacrimal gland, and the conjunctiva contains very small accessory lacrimal glands, some small conjunctival glands, yeah? And it forms such a small structure here, which is called a small strawberry lacrimal caruncle. It's in medial angle. So the conjunctiva is an epithelial tissue covering the internal or posterior surface of the eyelid and the visible part of the sclera. Yeah? And it helps the eyelids to smoothly slide over the sclera and cornea. Okay, eyelids. What are eyelids? The eyelid is a fibrous structure. This is the orbital septum, here and here. So it's the frontal plate. Into the frontal plate there are put two another fibrous plates, which we called tarsus. You know, the tarsus is the part of the foot where we have the tarsal bones. Tarsus is also a city in southern Turkey where St. Paul was born. But Tarsus is also this plate. Yeah, you can see it's quite a longitudinal plate. The upper is twice thicker than the lower, and the upper can be everted, yeah, can be flipped, and you can flip it maybe using a match. If you take a wooden match here, yeah, and you put it here, so you can flip the upper lid this way, and you can look into the sac below, to the conjunctival sac, and to see if there is any inflammation or a foreign body. So that's called eversion. It's called eversion of the upper lid. It is not necessary to perform it with the lower lid, as the lower lid is smaller and it is easy to look behind that. So these are the lids and their tarsi. What else we have here? The eyelids are fixed by ligaments. Yeah, we call it palpebral ligament, medial and lateral. The medial has got two bends, as we have two lacrimal crests, anterior and posterior, and in between we find the structure which is lacrimal sac. So the lacrimal sac is in between these two bends of the medial palpebral ligament. Then here are some terms. Rima palpebrarum is the slit between upper and lower lid. Commissure is, of course, this area, that's the commissure. Anterior face, posterior face, yeah, the anterior covered by skin, posterior by conjunctiva. Limbus is, I'll show you on a section, yeah, what is limbus. And of course, annulus, or in Greek is called canthos, or the Latinized version canthus is another word for the medial or lateral angle of the eye. Yeah. Superinferior tarsal muscles are smooth muscles which are related to the extraocular muscles inserted. That means to levator palpebrae superioris and close to inferior oblique. And of course, the palpebra contains the orbicularis oculi muscle, its palpebral part innervated by facial nerve. So then in palsy of the facial nerve, we have of so-called lago almus, yeah, and we have a muscle elevating the upper lid, supplied by oculomotor nerve. So here on the section, which is a histological one, so I don't talk about all the details. You can see the anterior surface covered by skin, posterior surface covered by conjunctiva, and this is anterior limb, and here we have the posterior limb. Yeah, so this is anterior posterior limb. This is the plate, fibroelastic plate. That's the tarsus. Yeah, that's the tarsus. And what you can see inside the tarsus is a gland. So there's a big gland, and the gland is called tarsal or Meibom's gland. Please learn this name, as if this gland is blocked, yeah, then there's a very painful, swollen, dark structure which has to be cleaned, sometimes cut, sometimes it's treated only by an ointment, and it's called chalazion when it's blocked. Yeah. So you can think like if you have the acne on your face, then these are the blocked sebaceous glands on the face. Yeah. But if it's on the eyelid, it's very painful, and it's also dangerous for the cornea that you can scratch it. But we have more of these glands. We have sebaceous glands of size. Yeah. And these size glands, they are located in these areas. They are classical skin sebaceous glands. And if they are blocked, it's called hordeolum with similar symptoms. Yeah. So these two terms, please learn as you will use them in ophthalmology, and remember these two glands. Of course, we have some other glands. We have ciliary apocrine, Mohs glands, but there is no specific disease related to these. Important information: no adipose tissue in eyelids. Yeah. So this is what you will talk about in detail in histology as well, but it's important not to skip the eyelids. Yeah. Okay, and you can see the eyelid here with the plate. That's the tarsus, and here is the skin part, and you can see the muscle, which is the palpebral part of orbicularis oculi muscle. Lacrimal apparatus. Lacrimal apparatus produces tears, and tears are important firstly for feeding cornea, and secondly for cleaning the area. So yeah, we can make the functions here. So first it's nutrition of cornea, of course, together with the capillaries from sclera and conjunctiva and with humor aquosus. Then it's cleaning and also some immune function, yeah, as the secretion can kill the bacteria. And the third is smooth sliding during blinking. Yeah. So these are the functions of the tears. Of course, the tears are then produced in lacrimal gland, which you can see here. The lacrimal gland has got two parts, orbital and palpebral, as it's divided by the orbital septum. Yeah, so just morphologically two parts. It's not one gland, it's more glands altogether, so they have more than 10 excretory ducts. And then we can have some accessory lacrimal, very small glands, which are within conjunctiva. Okay, then the area between the margins of eyelids forms such a river. So lacrimal river or lacrimal creek or brook, it's called rivus lacrimalis. Yeah, so that's the whole area of the slit between the eyelids where the tears flows, and tears flow from superior lateral aspect to inferior medial aspect and then down into nasal cavity. Yeah? Okay, so we continue and we come to here where the river Rivus enters a lake, Lacus. And in the lake, we have the caruncula, like an island. And the caruncula is a conjunctival structure. And then we have two openings of excretory ducts. And these openings are at the margin of the eyelid. So you can nicely see them if you look into the mirror. So we call them points, puncta. And from these canaliculus start. We have superior and inferior. So what is not drawn in the figures that they go like this, then they are bent, then they are fused, and finally they open into a sac. And then the sac goes down. So this is a sac. This is common canaliculus, yeah, superior and inferior. This is the punctum. And don't forget, please, this bend, which is not much drawn in figures, but it's important. Why it's important? The excretory lacrimal ducts are not opened when the baby is born. Yeah, they are luminized during first 6 to 12 weeks after the birth. And if they are not luminized, wait a little bit, and then if they are still not luminized, you have to put a wire inside, and you have to artificially make them open. Yeah. So you have to know what is the direction of these canaliculi. Okay. So then from the sac it goes through the nasolacrimal duct into inferior nasal meatus. Yeah. Inside you can find many little fine folds. The folds possess an eponymic names. Do not learn them. Yeah, it is not important. So that's it for the lacrimal apparatus. It's possible to see the own river. Yeah, if you look into the eyes, you can see the space in between, but you usually do not see it as a river. Maybe you can ask your friend just like to lie, to close the eyes, not not totally, and then you can see a bit of the flow there, but it is not like a river that you see the current. It's just a accumulation of the tears. Yeah, it's more poetry than a real structure. Okay, figures for the same. Histology. Muscles. Nothing new to say. Yeah. Very quick revision. 4 recti, 2 obliqui, 1 levator of the upper lid. All this supplied by trochlear, abducent, but mainly oculomotor. Smooth muscles, orbitalis muscle in inferior orbital fissure, superior and inferior tarsal muscle in upper and lower lid, supplied by sympathetic, parasympathetic. Please, this figure is important to understand, as you can see it on MRI and CT. Oh, mainly MRI. Yeah. These are recti, superior, lateral, medial, and inferior. Then you have 2 obliqui muscles, superior and inferior. And of course, levator palpebrae superioris. Yeah. So please learn this figure passively, so it can be one of the figures in the test as well, as it is similar to MRI. Yeah. So that's why it's important to understand it. The movements of the eyeball, we have talked about that in cranial nerves lecture, so do not forget terms version and vergence. Yeah, version means that you move both eyes in the same direction. Vergence, that you move each eye in different directions, so you have a convergence and divergence. Yeah, so nothing new here. And just to conclude, how you can examine the eye. So to nicely examine the eye, you can use a slit lamp. Yeah, you can see the slit lamp here. You will use this in ophthalmology. But you can examine it with the ophthalmoscope. Yeah, the ophthalmoscope then shows you this. This is the fundus of the eyeball, and please learn to draw it. Yeah, the macula, the optic disc, and the temporal superior and temporal inferior arteriole nasal macular. Yeah, this is what you should draw, as you should understand it. Here you can see an enlarged papilla, a swollen optic disc, or it's called papilledema. Yeah, and it's a symptom of raised intracranial pressure. Raised intracranial pressure due to injury and bleeding, humor, blockage of drainage of cerebrospinal fluid, for example. Yeah, so very important. Then perimetry. You ask the patient to look into an instrument or device which looks as a satellite, and the patient has to follow a spot of light, and then you can see the field of the vision. Yeah, so you see the field of the vision, and if there are some smaller areas, blind areas, we call them scotoma. If they are larger, we call them quadranopsia or hemianopsia. Yeah, there can be, of course, the macular sparing. So that's perimetry. Then optometry. Yeah, you would like to find out how many diopters you need. So either use the optometer or use an optotype, and this is the Snellen eye chart, which is used across the world. And I think everybody of you has seen this and use it. And of course, OCT, the best method to show where is the problem. So these are the basic examination methods for which you need the anatomy. And finally, there are some symptoms and the names which you may use. Epiphora, excessive lacrimation. Yeah, this term you can use easy. Then the patients wearing glasses are either myopes or hypermetrops, so they have problems with vision to the distant or to the near objects. Please do not mix it with hypermetry. Hypermetry or dysmetry is the problem of cerebellum, yeah, that you are not able to target your movements precisely. Okay, presbyopia, when you get old after 40 years of age, so in my age, you can have and usually have problems with vision. Yeah, you are usually hypermetropic. Hemeralopy, problems with vision in dark areas, yeah, mainly in the dusk, during the dusk or dawn, yeah, usually in myopes. Amblyopy is a functional problem, and it's a problem if you have a squint, then you have a dominant and non-dominant eye, and the brain switches off the non-dominant eye. So you need to close the dominant eye, so the brain again switches on the non-dominant eye. Yeah. So please, if you have a kid with a squint, it has to be treated early. Yeah. Otherwise, the one eye will get blind functionally. And daltonism problem with color vision, it's important that it's a hereditary disease, and it's important to get the driving license. If you are daltonic, you cannot get the driving license as you are not able to distinguish red, orange, and green color. Mainly blue and green are the main problems. So please, just to understand these terms as you will need them during your studies until you reach ophthalmology subject in the 5th year. And the development, it's also part of the histological exam, histological lecture. So that's all. It was long, but I hope you get an insight into the visual system, and you can then continue with the lecture in histology, and then with practicals in anatomy and histology as well. So do you have questions concerning the lecture?